What have we learned from Oregon, where doctor-prescribed suicide was enacted in 1994, setting the model for all other states? Anybody can answer this.
Are you going to be able to hear me, or
Yes.
would it be better if
You can hear it.
so a couple quick things. One is a very telling comment by a Dr. Toffler at the University of Oregon. He said the proponents of this say that everything is fine. Everything is not fine in Oregon. There is a, and I'm paraphrasing some of this, a heaviness that has changed our state into a society of death. Patients are fearful. Some of my long-standing patients who I've referred to a cancer specialist, and I didn't get a hopeful answer, will come back to me and say, is this doctor that you sent me to one of the doctors of death? So there's mistrust and a real unease in the society. And the second thing that we've touched on, as Dr. Laura mentioned, patients are depressed. Only 4% are referred for psychiatry evaluation. This has not been mandated in our bill in Massachusetts. They've tried to make some changes in the 2017 bill, but it's still not clear to me as I look at it. And then the other thing is that the prescribing doctor is not there 90% of the time. And one other biggie, there have been something like 1,700 prescriptions written for the suicide pills. They've been used 1,100 times. These are general figures. Where are the other 600 households with these pills? And we're talking about 100 pills of barbiturates. They're sitting in medicine cabinets with no oversight. And we all know the vulnerability of our teenagers, our other people who are depressed. So there are lots of problems in the law itself, apart from some of the other things we've discussed.
Next question will go to Dr. Lambert, and is, what are the driving forces, for example, the emotional and psychological factors behind the push for doctor-prescribed suicide?
So I covered a fair bit of that in the comments that I made already, but again, when you look at like early requests for physician-assisted suicide when somebody has initially been diagnosed, it's often just sort of an exploratory question, asking the physician, getting a sense of what their stance is on it as well, but also at a time when the person is just sort of facing their mortality for the first time, really hasn't figured out exactly, what the most important thing is. Later on, it becomes the issues that we talked about. It can be pain, but again, as Bill pointed out, we are at a point in history where we have the best technology for taking care of pain, and Vi can definitely speak to that as well. We can do a very good job of taking care of people's pain, and once that's taken care of, then there's the question of the depression. Again, we're not doing a very good job of referring people for a psychiatric evaluation and managing their depression. We can do much better at that. And I really think that once you've taken care of those two major top categories, then you're getting into that realm of existential suffering. And that's where it really takes a one-on-one human-human interaction to figure out what is driving that and how to help. It's not something that we can fix or cure, but it is definitely something that we can help to alleviate that sense of isolation, alienation, and the sense of meaninglessness in life. Just to point out, as you said, with the story about Brittany Maynard, the day before she posted on October 31st that this was not the right time. The day that she committed suicide, she actually went out for a walk with her dog and her husband. They had breakfast together. The law in Oregon says that the physician-assisted suicide is for when the suffering is unbearable. And that doesn't sound like an unbearable suffering day to me, to go out for a walk with my dog in the woods and have breakfast with my family. And so, again, it comes down to, in that case, she may have been coerced, so there is pressure for some people. But then, again, it's coming back to this sense of, you know, that sense of being, and that's what's driving, I think what's driving this.
Okay. That was a lot on emotion. Now we're going to move on. I'm going to have a question for Dr. Jessup. Who benefits from doctor prescribed suicide?
I mean, I think this is a very complicated issue. I mean, with healthcare in general, it lies in the intersection between your government and private interests. I mean, we've already seen this before. I mean, a lot of, you know, insurance companies, like we have multiple examples here, it's more cost effective for, you know, people whose treatment plan would be a lot more expensive, more cost effective for them to die. And same with the government as well. And I think, like, if you do, if this becomes, you know, legalized, hospitals will also start to feel that burden too, because they might want to treat the patient. The insurance companies won't want to reimburse it, so the hospitals will have to eat that cost. And eventually, you know, with all that financial burden, it slowly becomes, you have a society where, you know, death is a potential treatment option, and that can be very dangerous.
Right, I got another question for Vi. Are there any particular groups of people at increased risk of harm due to the doctor prescribed suicide?
So, and Dr. Bill already mentioned that, you know,
Yeah.
The minorities, disadvantaged, so economically disadvantaged folks, as well as you know, other minorities, poor people. The issue with that is, I mean, if you have, like, your mother, your grandmother, you know, fall, break their ribs, end up going to the emergency department, that for them to be treated, it would require, you know, huge amounts of treatment, including a stay in the ICU, and then, you know, long rehab. What's not to prevent, you know, physicians from saying, you know, maybe a better course for you would be, you know, maybe passing on rather than saying, you know, doing all this intensive treatment. And I think as far as physicians go, it's also harmful for physicians because, right, so for thousands of years we've been taught to be healers. And especially now we're supposed to be practicing evidence-based medicine. So we prescribe the best treatment for patients based on objective data. And if we would start to legalize physician-assisted suicide, you start flipping back to subjectivity because you're not going to have any data. No one's going to let you have any studies to see, well, will killing this person benefit them better than treating them? So having the subjectivity can also be very dangerous because it can affect your doctor-patient relationship, because what's not to stop a physician saying, you know what, you've had multiple heart attacks, you have terrible diabetes, I can guarantee that your life is going to be horrible, probably better off, you know, dying. And so you start running this dangerous road. We've already seen this, like historical examples of, you know, doctors that were given some subjective authority of who were allowed to live and die. And if you look at the Nazis, Operation T4, 7,000 people were murdered under the guise of, oh, we're just alleviating them from their suffering. Remember that trials showed that, you know, that wasn't acceptable. A lot of these doctors, you know, face a death penalty for that. But I can say, if you've run a slippery slope, and then, you know, the physicians, I think you need to realize that they can be adversely affected by this.
All right, the next question will be asked to Dr. Lambert. How will doctor-prescribed suicide impact the doctor-patient relationship?
I think I alluded to that as well. It's going to change the way we practice medicine. It's going to become an option for us that we didn't have before. Like anything else, once it's in the water and it becomes sort of normalized, then we stop. Where's that threshold going to be? Like I was saying, at some point, there's no way you're going to do a study. I think that's actually a great point that you can do a study comparing, is this better for somebody's life versus this treatment? You know, because once the person's gone, you can't really find out if they have would you like to compare it to? Again, I think once we, if it becomes normalized, and then we will start thinking about other options, and instead of having the patient request it from us, we will get to a point where we're actually starting to suggest it to patients, and I think that is the slippery slope that we're on.
If I could jump in and add one other thing and we're seeing this already in our neighbor Vermont, and the bill, again, in the State House, would demand that physicians refer for assisted suicide. So now we get into the issue of rights of conscience. If I know that this is the wrong thing to do, and the law says that I have to refer a patient if I won't actually write the lethal prescription. This gets into another whole area of disrupting the doctor-patient relationship and the physician's rights of conscience. None of our judges have the power to be the judge and the jury and the executioner. I mean, this is power unprecedented for physicians.
Yeah, I think he answered the next question anyway. My next question is going to be open to the panel on who's behind and pushing for doctor-prescribed suicide nationwide. I think he answered that, but you guys can all take a swing at it if you want.
I was going to take one swing at it. Some of you may be familiar with the name Derek Humphrey, who has written Final Exit that surprisingly became a New York Times bestseller in 1980. He was in England. His wife had terminal breast cancer and begged that he help take her life, and he did, and then he wrote about it. And I actually have a faculty member from one of our institutions here discuss this with me, and 50 years ago, he had a brother who was suffering from an injury. So this is out there, and this Derek Humphrey is the one who founded the Hemlock Society, which keeps changing its name. Verbal engineering, they've been Death with Dignity, and of course hospice provides death with dignity, and palliative care provides, so now they've changed the name to Compassionate Choices. But it's the same group. And the one point I'm making is that we're dealing with information from 40 or 50 years ago, and I don't know if we have a question for Vi on just the control of pain, but what we had to offer patients 50 years ago, 40 years ago, is different from today. I shouldn't take over.
No, I know you jump in. Yeah, I like that question anyway they asked for. But I'm running down to the last two questions, which I was going to combine anyway. So if I wanted to speak on that question offered up by Bill, please do.
I think I mean, with treatment of pain, just like Bill said, very advanced working. And then, so I mean, I guess the other thing concern you could have would be like, opioids have side effects. You might have been aware of like the opiate crisis, and there's a lot of side effects. We have medications that treat that as well. And I mean, I work in the ICU. I'm an intensivist, so I deal with a lot of end-of-life issues, including pain control. And it's not just one person, one physician that's treating this. I mean, as a physician, we have to treat someone's physical health, their mental health, emotional health, spiritual health, even. And with these, I mean, having this palliative care team, you have a whole army of physicians, social workers, other therapists that help these people out to give them their dignity, help them be comfortable, and then provide a support system for them too as they make their transition into the next life. And I've seen a lot of great benefits from that in terms of the patient care, and a lot of that it shifts the burden away from the families themselves, and we're a great support system to help facilitate that. I feel with physicians, suicide, you shift everything back onto the patient, and you, all the burden onto them, and I don't think that's right.
The next question is going to be, what have we learned from the experiences with doctors prescribed suicide in Europe and in the Netherlands since 1981? I think that's best to offer it up to Bill.
So this is also interesting, Joe, that I've been told when I had the opportunities to do some teaching at the State House, don't bring up Europe. Don't,
Oh, no.
yeah.
Sorry.
But yeah, we can't ignore what's going on in our neighbors to the north in Canada that has the most liberal laws just recently passed. So, and Dr. Laura used the term slippery slope or incremental increases. So what's happened is the law comes in and the proponents push it for unbearable suffering and a diagnosis, a terminal diagnosis of dying in 6 months. We've talked about unbearable suffering, but what has happened is the law continues, or the practice to expand, truly a slippery slope. So first the age limit. In the Netherlands, it's being extended to minors, and in Belgium, I think children down to 6 years of age can request it, which is, words fail me in mentioning that. And even in Oregon, but especially in the Netherlands, it's extended far beyond terminal illnesses. So first it was people who had other serious illnesses with neurologic disorders, multiple sclerosis. In Quebec, the Prime Minister of Health is trying to extend it to the people with any dementia. Chronic lung disease, you saw the lady in California that I showed you, but there have been other cases, diabetes. In the Netherlands, it's now for patients who are tired of living. And there are traveling euthanasia clinics. That's the other thing, that's euthanasia. And so the patients are actually being tattooed, do not take my life, do not euthanize me. And there have been a number of cases documented. Grandpa goes in with pneumonia, you come the next day to see him, and the bed is empty. Grandpa is up in years. The doctors decided that the life is not of such a quality to continue living and paying for it. And then it's being taught and mandated of how to perform euthanasia in the nursing schools and the medical schools in the Netherlands. So it just, the proponents for this, Compassionate Choices, would never say overtly that this is their goal, euthanasia, that somebody else can take another person's life, or any of these other things. This is clearly an opening wedge that we've seen played out in Europe and coming to Canada as well.
Right. I'm going to open up the last question to the whole panel on what are the dangers of doctor-prescribed suicide in Massachusetts, and what is the history in our Commonwealth? Anybody?
Before the dangers, so I think many of you know that this has been pushed since 1995. We're coming 20 years, and it's been defeated, or tabled. It's not been defeated. It hasn't come to the whole State House for a vote. But it's been killed in committee, so to speak. And with the $20+ million war chest, Massachusetts is the #1 state being targeted by Compassionate Choices this year. They are taking a 5-pronged approach, which is unprecedented, back in the State House. Most of you know it was defeated in ballot in 2012, and actually Senator Kennedy's wife and now widow was a very powerful spokesperson. Teddy Kennedy was given 4 months to live, and he survived 15 months and was able to go back to the Senate. And she said, doctors are wrong. But anyway, they're pushing probably to have this on the ballot in 2018. A lawsuit has been filed by a doctor in Falmouth that it's his constitutional right, and some people said, this is a doctor? You know, why doesn't he write his own prescription? But he actually has had improvement. But anyway, coming through the courts and suing our Attorney General has been one of the things. Compassion Choice is trying to neutralize the Mass Medical Society, Massachusetts Medical Society, which has been strongly opposed, and they are unprecedentedly going to town councils, asking town councils to vote in support of this, and then forward it to the State House. And the first one to pass support for doctor physicians who suicide is Cambridge.
Yes, of course.
People said they weren't surprised. But the laws, again, for Massachusetts are almost cookie cutter out of Oregon. The doctor doesn't have to be there. I said an heir can also sign. So the law itself, the bottom line is the safeguards in the law are an illusion. They just don't work.
So I mean, just in closing, like a lot of people that also listen, well, this is my choice, I should have a right to die. I mean, there's a couple of Supreme Court cases that say you really don't have a right to die. But, I mean, just keep this in mind, you know, these people who believe that they have a right to die will affect everyone else's right to live. Yeah, and so this is like this is the thing called right to life, right? And so I mean, I would encourage you guys to get involved with this